So now we're going to go into our special tests. I'm first going to start off with the wrist and then I'll go into the finger special tests. So the first one is the valgus stress test. So just like how we assess the UCL in the elbow joint, we're assessing the UCL down at the wrist joint. So valgus still pertains to UCL and varus still pertains to the RCL except at the wrist joint itself. So what I'm going to do is just apply light distraction. So that means I'm pulling the carpal bones away from the radius and the ulna. I want to have the patient to start out in anatomical position just to make it a little bit less confusing in terms of where the stress is being applied and on what ligament. So if I wanted to provide a valgus load, I'm going to again provide distraction and then stress the medial structure or the ulnar structures here for the UCL. If I wanted to do the varus stress test, again, I'm going to apply distraction, so just pulling the carpal bones slightly away from the radius and the ulna, and then just providing a medial to lateral or ulnar to radial tension along the RCL here. So similar to the varus and valgus stress test in the elbow, if there was any pain along the wrist UCL or RCL, or if there was excessive laxity or clicking that was painful, especially as compared bilaterally, then that would be a positive test. For the glides, so the naming gets a little bit confusing for students. If it's the name of the test, that means that the carpal bones are ending in that position. So for example, for the ulnar glide, the carpal bones are going to end on the ulnar side of the wrist. So again, I'm going to have Cole in the same position, anatomical position with his palm supinated. I'm going to provide light distraction again, pulling the carpal bones away from the radius and the ulna. And I'm just going to slide the carpal bones from the radial side of the wrist down towards the ulnar side. So the carpal bones are ending on the ulnar side of the wrist here. That would be the ulnar glide. Radial glide is the same thing. I'm just going to slide the carpal bones from the ulnar side of the wrist, ending on the radial side of the wrist. So it's a radial glide. Lastly, we have the dorsal and the palmar glides. So I'm going to have Cole just bring his arm down so it's his wrist is slightly off the table. I'm going to provide light distraction again. With a straight arm, I'm just going to push the carpal bones down. So this would be a dorsal glide because the carpal bones are starting on the palmar side of the wrist and ending on the dorsum or the back side of the hand here. If I wanted to do a palmar glide, I would just flip his hand over. Again, apply light distraction, and then just push the carpal bones down from the dorsal side of the wrist towards the palmar side of the wrist. So because the carpal bones are ending on the palmar side of the wrist, this is a palmar glide. Same as the varus and valgus stress test, if there was excessive laxity, any pain with that movement, especially compared bilaterally, that would be a positive sign for instability. Next, we're going to go into the finger special tests. So again, I'm going to put Cole back into anatomical position with his hands supinated upwards. I'm going to provide the varus and the valgus stress test, but at the IP and the MCP joints. So if I'm providing a ulnar to radial force, then that would be stressing the radial collateral ligament. If I was providing a force from the radial side of the wrist, the MCP joint, towards the ulnar side, this is stressing the UCL ligaments. And you can do this up the IP joints here for varus and valgus. For these ones, you can keep them fully extended and then just apply tension to those ligaments there. Next, we have the Phalen's test. So normal Phalen's is just having the patient bring both their hands up and they would compress their hands together in full flexion. So this would be just normal Phalen's. This would be, this is essentially compressing the median nerve. And what would happen is the patient would lose or have some paresthesia into specifically digit 3. If I wanted to do a modified Phalen's with my patient, I'm just going to passively bring him into 90 degrees of shoulder flexion, 90 degrees of horizontal adduction, and then maximally flex his wrists for about 30 seconds or so. Lastly, we have Finkelstein's test. So Anytime that I am bringing my patient into this position, I always just ask them to be very, very careful because it's really, really sensitive. So I'm going to ask Cole to make a thumbs up. He's going to put his thumb underneath his forefingers with his wrist flexed, so like this. Yep, flex up. And then very gently, he's going to ulnar deviate, bringing his whole palm, or excuse me, his whole fist down towards the ulnar side of his wrist, so very slowly. Do you feel any pain here? Are you okay? If there was any pain or if they noted any crepitus, that would be positive for something called tenosynovitis. Tenosynovitis just means it's the inflammation of the sheath that surrounds the tendon, and that's what differentiates that from tendinitis. So that would be for the extensor pollicis brevis or the abductor pollicis longus, which is within that anatomical snuff box.